All right, good morning, everyone. Looks like I got everybody checked in. Welcome. And I'll just go ahead and turn things over to Renell.
Hey, Chris,
Yes.
do you have any housekeeping things you need to do first? I'm just signing on with my iPad.
Okay, gotcha. Let's see here. Yeah, just a quick reminder, we will do lab tomorrow. We'll be doing an all-day lab, so I'll see you all at 9 in the morning. And let's see, as a reminder, final exam is going to be on Tuesday, next Tuesday. And there is quiz number 3. Quiz number 3 should have just opened for everybody, and I believe it will be due, let's see, by Tuesday morning at 0800. So make sure you work through that. It's not a huge quiz. It's comprehensive. So it'll have more concepts, strips, etc. on it. And then let's see, for today, we'll be talking about more advanced concepts. So we'll be talking about, I believe we'll be starting off with bundle branch blocks. And we've already kind of peripherally discussed them a bit, but today we're going to talk about how you robustly identify a bundle branch block and differentiate right from left and turn signal criteria. And then we'll talk about some of the criteria that we can use to tease out or differentiate a STEMI from a bundle branch block. But I want to be very clear. The general rule of thumb when it comes to this stuff is as follows. All right. If you have a patient with a new onset or a presumably new onset left bundle branch block, and they have signs and symptoms of an acute coronary syndrome, our default should be that they are having a STEMI until proven otherwise, or they're having an acute coronary syndrome until proven otherwise. All right. So I want to throw that out there, that we're going to talk about a lot of advanced and nuanced stuff, but that's kind of the general rule of thumb when it comes to this stuff, because it can be difficult to tease out what concordance and discordance and so on and so forth. So I will go ahead and with that preamble out of the way, I'll go ahead and turn it over to Renell to talk about some of these more robust concepts.
Okay, good morning. Can everyone hear me? Chris, you can hear me?
Yes, sir.
All right.
Yeah.
Okay. So as Chris stated, we are going to get into a little bit, a little bit of the more advanced electrophysiology this morning. I will tell you that I will be happy at this point if you can just grasp the basics, because there is a lot of information here and there is a lot of ways to get off onto different bunny trails and to think something is one thing and it actually be something else. So I want to do my due diligence in reiterating what Chris said, in that if there is any doubt at all what you're looking at, take the most, I would say, conservative response. In the exception, an exception would be is if you're dealing with a STEMI. If you have any question on whether, hey, is this a STEMI, is it not? It's best to treat it as a STEMI per your clinical practice guidelines or your protocols. It's better to do it that way than for you to, not pick up a STEMI and not treat it as a STEMI, and you end up with a lot of issues. So I just wanted to reiterate that. And with that, excuse me for 1 second, I need to close my office door here.
I hear the cackling.
Okay, so let's begin. And the way we're going to do this first is I'm going to present you with a situation. So let's say that I am going to meet you somewhere, and then I'm going to meet you at a location, and we are going to then go to another location together. So I arrive at this location early, and I leave without you. So you get to the first location, and I'm not there, and you're wondering, hey, where the heck is Ronell? So you finally get someone who saw me leave, and you said, hey, where did Ronell go? And they, look at you straight in the face, and they say, Ronell left here at 60 miles an hour. Can you tell me, is that really a useful piece of information? So this is a question for you guys. Is that a useful piece of information if someone were to say, Ronell left here at 60 miles an hour?
No, not really.
Yeah, what's the matter? What's missing in that information?
Which direction did he go?
Yeah, absolutely. Absolutely. So in that first answer of, hey, Ronell left here at 60 miles an hour, they answered you in a way, in a term that we call in physics a scalar. Okay, a scalar. And what a scalar tells us is just magnitude, or 65 miles an hour would be just the magnitude at which speed I was moving. It doesn't tell you anything about what direction I would be moving in. So as Nicole alluded to, it would be more helpful if I got, you got information that gave you not only a speed, but also a direction. So if that same person were to tell you, Ronell left here going 60 miles an hour, and he was headed due west, that is much more helpful, isn't it? So this concept is known as a vector. In physics, when we start talking about kinetics and movement of forces, we have two different types of values. As I said before, we have we could have a scalar value that would just tell you magnitude. And then we have a vector, which not only tells you magnitude, but also tells you direction. Now, in physics, in order to have a visual representation of this concept of vectors, we use a convention. We use arrows. So the tail of an arrow, so that would be just a line before the head, the tail of the arrow, by convention tells you the magnitude of a force. So the shorter the tail, the lesser the force, the longer the tail, the greater the force or magnitude. And then to delineate direction, we'll use the head of an arrow. So if we wanted to say we have a certain force moving with a certain magnitude to the left, we would make a head of an arrow go to the left. And that's a little bit, you all have to, again, I'm going to ask your forgiveness for my artwork. But there we go. That probably is a better looking arrow. So we know that that force is moving to the left at a certain magnitude. Okay. And if we wanted to have a vector that shows a force moving downward, we would give it a certain magnitude or a certain length tail, and then we would put a head on it to show that that force was moving downward. Okay, is everyone with me? So let's say here we have two different vectors. We have a vector going left and we have a vector going down. And we wanted to know the general direction that both of those vectors we're pointing in. Then we use something called vector addition. Okay, and I don't want to get too far into the weeds, but what we end up doing is we'll use a method called the head to tail method to actually add these vectors up and then get an average. And that would give us a general direction that these vectors are moving in. Okay, so I want you to think of this, with particular, with your grades. When we average your grades, you have a group of numbers and you add them all up. And of course, you divide by the number of grades you added, and that will give you your average. Things to know about an average, as we know, an extremely high number in your grades will tend to pull your grade average in one direction, and extremely low grades will tend to pull your average in an opposite direction. Okay, so let's transpose this concept to talking about forces in the heart. All right, so let's talk about, once again, averages. So if we were to add these two vectors up, a vector to the left and a vector heading downward, or force heading downward, and we wanted to get the average of these two vectors, would it be reasonable to assume that the average, or the middle, would be a vector something like that, splitting the other two vectors in half? Does that make sense to everyone? Is everyone with me so far? Okay. All right. So when we are talking about electrophysiology and forces in the heart, we use this concept of vectors and averages to look at the movement or propagation movement of electricity in the heart. And we call this vector, this average vector, remember this middle vector that we got by adding up the two other vectors and then dividing, we call this average vector axis. So I want you to think of axis as nothing more than the word average, or the general gist of the movements and forces in the heart, the general gist of the direction that those forces are moving. So in our heart, we know that we have let's talk a little bit again about the basic conduction system of the heart. We know that in the right atrium, we have the SA node, and then that goes down into the AV node. And then once that electrical impulse gets held up for a second, it then propagates into the bundle of His, and then it propagates into the left and right bundle branches. Okay, and curiously enough, the right bundle branch has what's called a fascicle, one fascicle, and the left bundle branch has actually two fascicles. And those fascicles are called the anterior and posterior fascicle. Okay. Is everyone with me so far? So if we were to apply our concept of vectors to this overall mental picture, what we would see is a impulse coming from the SA node. And let's clean up a little bit of our mess here. Coming from the SA node, and it would propagate downward and around, downward and around. And you have all these vectors moving downward and to the left and around. But the average of all these vectors is downward and to the left. Okay. Any questions so far? Chris, anything you want to add here?
No, sir.
Okay. So, from all that gobbledygook, what I want you to remember is that axis is defined as, or is equal to, the average. Okay? The average. So, and again, the average movement of forces, the general direction of forces in the normal heart is moving downward and to the left. That is our axis. That is our vector, downward and to the left. Okay. So, what does this look like on an EKG? How do we apply this on an EKG? So, fortunately, we have 12 leads. And remember I said, a 12 lead is nothing more than you looking out a window pane, a window with a lot of little panes, and you seeing, different sides of a picture outside, different things outside in different panes. So fortunately, we have 2 window panes that we like to use to determine our cardiac axis. And those 2 window panes, or those 2 leads, would be lead 1 and lead AVF. Okay? Lead 1 and lead AVF. Now, how does this work? Well, we need to remember this, this triangle called Interven's triangle. And, we have this plane and 3 particular leads make up this plane. And we remember, Chris went over this, that lead AVF is this leg of the triangle. Oops, I'm sorry. I don't want to, that was incorrect. Getting a little ahead of myself. So at the top of this triangle, lead 1 resides, and lead AVF resides at the apex, or the bottom, of this triangle, of Interven's triangle. So remember that we said that you have your leads and they have their, sort of, for want of a better word, electrical poles. All right? And we know, or we remember, that the negative pole of lead 1 is located on the right shoulder, And the positive lead of lead 1 is located on the left shoulder. And with AVF, the negative lead of AVF is on the right shoulder, and the positive lead of AVF is on the left foot. Okay. So remember we said if you have an impulse or a force or a vector traveling away from a negative lead and towards a positive lead, that's going to give you what type of deflection on an EKG? And I know we covered this. What's that? Yes. I know we've covered this time and time again, and we're intentionally doing this because the more times you hear it, the greater the chances that you're actually going to absorb it and retain it, and then hopefully be able to apply it to your patient care situation. So we know that when an impulse is moving away from a negative pole towards a positive pole, we are going to get a positively deflected impulse or vector on the EKG. So likewise, you remember that if an impulse or a vector is moving away from a positive pole towards a negative pole, you're going to get a negative deflection or vector on the EKG. Okay, everyone remember that? And then if you have an impulse, finally, that moves perpendicular to a negative and positive lead, you are going to get this isoelectric, or I'm sorry, this equiphasic vector on an EKG. So it would probably look something like this, where you have just as much complex above the isoelectric line as you do below the isoelectric line. Everyone with me so far? Okay. So now let's apply this to determining a vector on EKGs. And I use these two leads intentionally. This is the two leads we're primarily going to look at to determine axis in an EKG. Those leads are lead 1 and lead AVF. Okay. Remembering that, again, lead 1 resides up here. Oops. Sorry about that, guys. And lead AVF resides down, for the purposes of this illustration, the apex of the heart or the left foot. Okay. Keeping this mental picture in mind is going to be helpful in order to determine appropriate cardiac axis or determine cardiac axis, period. So let's look at cardiac axis in the normal heart. what is normal cardiac axis? So remember we said, and this is just the ventricles, but remember we said the initial impulse comes from the SA node. And as it comes from the SA node, it goes downward and to the left. Okay? So if you have an impulse that is moving downward and to the left, what type of deflection would you expect to see in lead 1?
Positive.
Absolutely, you would expect to see a positive vector or positive QRS. Likewise, if you're looking at AVF, remember that impulse is moving towards AVF, and the positive lead of AVF is at the apex of the heart. You would see a positive deflection or positive vector in lead AVF. When you have these conditions, this is considered normal axis. So in the normal conduction system, the general gist, the average of our forces taken as a whole, is moving downward and to the left. Everyone good there? Chris, anything you'd like to add?
I'm good, sir.
Okay. So that is normal axis. Let's look at some derivatives of that. So again, let's look at a common finding, which would be left axis deviation. As the term suggests, left axis deviation is when, and I'm going to draw it pointing to the left. However, it's good for you to remember that these forces don't exactly travel in a straight line. These forces actually travel more in a kind of a swooped kind of downward and to the left and back behind the heart. Okay, but for the sake of simplicity, we're going to keep it that left axis deviation means that we have an impulse traveling in this direction. So applying what we know to this situation, we have this axis or this vector, I should say, traveling away from the positive pole of AVF and toward the positive pole of V1. Can we agree that this vector is actually moving towards the positive pole of lead 1, but away from the positive pole of AVF? So we said that since we're moving away from the positive pole of AVF, that's going to give us what type of deflection? It's going to give us a negative deflection or a negative QRS. But we're still traveling, this vector is still traveling towards the positive pole of lead 1. So we can expect to see a positive vector or a positive QRS in lead 1. This is defined as left axis shift or left axis. Okay. Everyone good so far? And finally, since this is recorded, I'm going to go ahead and erase so I don't run into my next picture here. So let's erase this, remembering that this is left axis. What we have left is right axis deviation or a right axis. So in a situation of a right axis deviation, in other words, forces moving upward and to the right, our vector moving upward and to the right, remember in lead one, again, the beam force is moving away from the positive pole of lead one towards the negative pole of lead one. So that's going to give us a downward deflection in lead one. And in AVF, you're also going to see a downward deflection. When there is a negatively deflected QRS in lead one and a negatively deflected QRS in AVF, this is known as right axis deviation. Everyone good? Okay. So an easy way to remember this. I'm going to age myself a little bit here, but there used to be a show on called Happy Days, and this guy named Fonzie, and he would walk around and he'd go, hey, he'd give you the A sign, with your fist clenched and your thumb pointed up, and he'd go, hey, everything's okay, right? So I want you to think about that when we talk about axis deviation. Okay, so this is what we need to remember. If you have one thumb, so if you have a positive QRS in lead one and a positive QRS in AVF, two thumbs up, everything is okay. That is normal axis. Okay. However, if you have a positively deflected QRS in lead one, but a negatively deflected QRS in AVF. So positive in lead one, negative in AVF, left axis. Okay. Axis, full axis. And finally, if you have a negatively deflected QRS in lead one and a negatively deflected QRS in lead AVF, you have a right axis deviation. And then there is a situation that is fairly rare, known as extreme right axis deviation. Extreme right axis deviation. I don't want to get into that. I just want you to know that that is out there. I think it's enough for you all to remember normal left and right axis. And we may add, I may add on to that as we start talking a little bit more about the pathophysiology. I may venture into extreme right axis deviation a little bit more. Okay, so that is just a very quick down and dirty way of determining axis on your EKG. So let's review. Axis means nothing more than the average. And when we're talking about the electrical forces in the heart or electrical impulses in the heart, we are talking about axis, which is the average or the general gist or the general direction that forces are moving within the heart for the heart to depolarize and contract. Okay. The two leads that you need to remember primarily to get just a very quick down and dirty determination of axis is both lead 1 and lead AVF. We need to remember that if we have a positive lead deflected QRS in lead 1 and a positive lead deflected QRS in AVF, 2 thumbs up, we have normal axis. Everything is good. If we have a positively deflected QRS in lead 1, but a negatively deflected QRS in lead AVF, we then have left axis deviation. And finally, if we have a negatively deflected QRS in lead 1 and a negatively deflected QRS in lead AVF, we have a right axis deviation. Okay, now let's put some numbers. That's the really quick down and dirty way to determine axis. But axis also comes in degrees. So let's put some numbers to this axis and what are the normal numbers? Because on your EKG, on your 12 lead, you will not see arrows or vectors pointing up or down to tell you which way the axis is traveling, which way the mean or the general gist of the energy is traveling. What you are going to see is you are going to see axis delineated in degrees. And that axis is it's going to be labeled QRS axis, and it's going to give you that in degrees. So in degrees, normal axis is between 0 and 90 degrees. That's considered normal axis. And that makes sense, doesn't it? Because if the AV node were up here in the center of our degree circle, that's the AV node, we remember that our vector is going to travel downward into the left in the plane of normal axis. Okay, so that is normal axis. 0 to 90 degrees is considered normal axis. All right. However, we are also talking about the abnormal. So in the abnormal heart that is experiencing a left axis deviation, you may also hear it termed as a left axis shift. Same thing. A left axis, so really quickly, let's put normal axis. Is defined as anything that falls between 0 and 90 degrees. Everyone good there? Hey, Chris.
Yeah.
Hold on one sec. All right, I'm going to take let's take a quick break here. Unfortunately, my iPad is shut down and I have no clue why. But let's take a quick 10-minute break and we'll come back and we will continue where we left off. So 10 minutes, everyone. Jesus, Pete. My iPad is super hot, Chris. So, all right, let's pick up where we left off. I apologize. For some reason, the thermal protection on my iPad is kicked in and shut my iPad down. But my iPad is kind of old, and when you get old and decrepit, you have problems, getting up and get going in the morning. So we'll revert back to your class notes, and hopefully I've got my iPad in the refrigerator. Hopefully it'll cool off and I can get back to some of my own notes here. But we're going to roll with the punches, and we're going to continue our talk. When we left off, I believe, at assigning degrees to axis. Okay. And I think the last thought I left off on was normal axis is defined as anything that falls between 0 and 90 degrees. Okay. So if you were to look on your 12-lead EKG and look for QRS axis, the degrees that you should see should be between 0 and 90. And that makes sense because, again, the general direction of the forces, the general direction of depolarization in the heart is moving from the right to the left and downward. Okay. So let's talk about, oops, we're at right axis already. Okay, so let's talk about right axis. Right axis deviation is defined as anything that falls between 90 degrees and 180 degrees. So again, if you look at your QRS axis on your 12 lead, if it falls between 90 and 180 degrees, that would be determined as a right axis deviation. And Chris put some pathology here, what could cause right axis deviation. Well, right bundle branch block, which we'll talk about in a little bit, right ventricular hypertrophy. And let me ask you, why do you think right ventricular hypertrophy would cause a rightward axis shift?
Because it takes more electricity to make that large ventricle contract.
You're exactly right. So you're actually going to have more force required, so more vectors moving downward and to the right in your right ventricular hypertrophy as opposed to your normal heart, and that is going to pull your axis to the right. Remember, we talked about our grades and averages. Anything that increase, if you have an extremely low grade, that's going to pull your grade in one direction. Well, you have something happening here that is an extreme increase in force. So that's going to shift your axis rightward. All right. Pulmonary disease. Why would pulmonary disease cause a right axis shift? And pulmonary disease and cor pulmonale kind of go together. So can someone tell me, knowing what you know about the cardiovascular system and how everything is interconnected, why in the world would you get a right axis shift with pulmonary disease or cor pulmonale? And remember, when we talk about cor pulmonale, we're talking about the vasculature in the lungs being, for want of a better term, tight. So the blood, the blood is confronted by more force, requires more force to push through the vasculature of the lungs. So why would that cause a rightward axis deviation? And it ties right into right ventricular hypertrophy.
Because the right ventricle is working harder than it needs to be.
Yeah, it's working harder than it should. And so there's more force required to cause the right side of the heart to contract. There's more, and as that muscle experiences hypertrophy, as you get this muscle that is increasing in size and density, you're going to have more electrical forces there, more tissue there, and therefore you're going to see a depolarization of that, the depolarization, I should say, of that thicker ventricle is going to show up on an EKG. Okay, so very thin left posterior hemorrhagic block. We're going to talk about blocks in just a little bit, okay? So let's move now from right axis deviation. Again, the definition of right axis deviation would be an axis between 90 degrees and 180 degrees. Okay, so we've looked at normal axis, which is anything that falls between 0 and 90 degrees. And now we've looked at right axis. So that leads us to extreme right axis. And this is one I said that I really, don't want to spend too much time on. Right axis is also known as kind of no man's land. It does occur, but it is relatively rare when you have axis deviation, but it is possible to see a extreme right axis deviation, and that would be defined as anything that falls between positive and negative 180 degrees to negative 90 degrees. Okay, so anything that falls between negative 180 degrees and negative 90 degrees is going to be considered extreme right axis deviation. And some of the reasons why you would see this, so ventricular hypertrophy or ventricular ectopy, and you may see this when we start looking at ventricular tachycardia, and you'll be able to differentiate VTach from, let's say, SVT with a widening QRS or endoventricular conduction delay. Pvcs, VTach, right axis deviation, and myocardial infarction. So why would you see an extreme right axis deviation in myocardial infarction?
Is it because of the ST elevation?
No. So remember, we say that in the normal heart, where we have our left ventricle is thicker than our right ventricle, therefore we have more forces, for want of a better term, propagating in the left ventricle, so that naturally brings our axis downward into the left. So think about it. What is myocardial infarction? What is it? What does it do physiologically? Just
Tissue injury or
myocardial infarction is death of heart muscle. Okay. So if you have someone who's had a left-sided myocardial infarction, think about it, those cells are dying off. And as those cells die off, they propagate less and less force. As you lose more cells, their ability to propagate an electrical impulse is also reduced. And if you have a reduction of forces in the left side of the heart, what does that do? What is the EKG going to see? Well, the 12 lead is going to see the right-sided ventricle having more force because it is unaffected. There's no cell death occurring there. But in the left side, you have cells dying off. And since you have cells dying off, less force, you're going to have a skewing of the axis, or the mean forces. They're going to skew to the right, to the extreme right. And the same could happen on the right side. If you have death of the right ventricle, you can actually see a left axis deviation, a pretty severe left axis deviation, because the forces in the right side of the heart are no longer there to kind of balance out the vector. And so the vector is pulled more to the left. Okay, does that make sense to everyone? All right, next. Let's talk a little bit about pathological versus physiological. So can someone tell me what the difference is between the two? So what does physiological mean? What does physiological mean? Okay, so physiological, for a simple definition, physiological means nothing more than a condition exists, but that condition has really no malignant effects, no negative effects on the functioning of a body system. Okay, so physiological means that there is a finding, it exists, but it has no negative effects. Okay, so in the case of physiological left axis, all we're saying is that, yes, there is a left axis deviation, there is a left axis shift, but that's not really causing any problems. There are really no pathological consequences associated with this left axis deviation. And a physiological left axis deviation is defined as anything that falls between 0 to negative 30 degrees. Okay. In juxtaposition to that, we need to discuss what a pathological axis, left axis deviation is. So if we said physiological is that there's something there, there's a finding there, but it has no consequences, no physiological, or I should say pathological consequences, no consequences on the body or the system. What does a pathological mean? What does pathological mean? So pathological means that a condition exists and it is having a negative, it is having a deleterious effect on the operation of a system. Okay. So in pathological axis deviation, we're saying, yes, there is a left axis deviation and that has some pathological consequences with it. Okay. And that is considered pathological left axis deviation would be anything that falls between negative 30 degrees to negative 90 degrees. Okay. Anything that falls within that realm is considered a pathological left axis deviation. Things that can cause this pathological left axis deviation: obesity. Why would that be? Why would obesity cause a left?
The heart is misplaced in the body. It's turned.
It's okay.
Hypertension, maybe, and usually they have the like ventricle hypertrophy, left ventricle hypertrophy.
Okay, I will tell you. All right. So let's go with the first answer about the heart's location in the chest cavity. Okay, that would be more of a physiological left axis deviation than a pathological left axis deviation. And why would that be? Because maybe the person is laying a certain way and the heart is kind of shifted in the thoracic cavity to the left, and the EKG kind of picks up on that. But that doesn't necessarily mean there are physical or pathological consequences associated with that mislocation of the heart. It may just be positional. However, with obesity, you have a whole plethora of things that are probably associated with that. You have a whole plethora of what's called comorbidities associated with that condition. So obese people, they're bigger. Guess what? What does that mean in terms of their physiology? When somebody, is obese, what happens to the rest of their physiology? As they grow, a lot of their physiology grows with them. Okay, so if you're obese and morbidly obese, your heart grows as, not only do you get larger, but your heart may enlarge. Your liver will enlarge. Your spleen will enlarge. The only exception to that, and this is a critical factor to remember as you move forward in your practice, especially in critical care, when you start talking about ventilators and tidal volume. Everything grows in an obese patient as the patient grows, with the exception of what organ? And I kind of given it away, but think about it. What is it?
Lung.
Absolutely. Absolutely. In the presence of obesity, the rest of your organs tend to grow with you, but your lungs tend to stay the same size. So what is the point here? Well, just because you weigh 400 pounds doesn't mean your body can take 1,000 cc's of tidal volume. And I don't want to go too far down that hole. I'm sure you'll get there. But just remember that in obesity, everything grows, but the lungs typically stay the same size. So if you're 5'4" and 400 pounds, you're going to take the tidal volume of somebody who's normally 5'4" and of normal weight for that height. Okay. All right. So obesity tends to enlarge the heart. And when you enlarge the heart for several reasons, just plain growth in mass, but also growth because as you get larger, the heart has to work harder to open up the aortic valve and push out blood against that, a force in the vasculature, afterload. And that kind of makes the heart, that grows the heart, and the heart becomes enlarged, and you have ventricular hypertrophy. Okay. Obesity also tends to lead towards cardiomegaly and cardiomyopathy, which is an enlargement of the heart. And with that enlargement of the heart, you'll start to see pathological left axis deviation. Ascites, left anterior hemiblock, which we will talk about, pregnancy, and inferior wall MI also can cause a pathological left axis deviation. Okay, so any questions there? Everyone with me? All right. So how to determine axis? So remember, this is our first practice. And again, I apologize for the shutdown of my iPad. I had a lot of practice, 12 leads, so we could determine axis and break down axis. This may hamper us a little bit when we start talking about bundle branch blocks and Scarbosa criteria, but hopefully I can have that issue addressed before then. Okay, so how to determine axis? Let's look at this EKG. Now, someone tell me, what two leads did I say that we primarily focus on in order to get a general idea of our cardiac axis?
One and AVF.
One and AVF. So what's going on in lead one? Do we have a positive, essentially positive or essentially negative deflected QRS in lead one?
Positive.
Yeah, I would say it's essentially positive. Okay, so we have a positively deflected QRS in lead one. What about AVF?
Positive.
Okay, it's positive. So what would that lead us to believe in terms of axis? Well, Chris has it written there. This is normal axis, is it not? Okay, normal axis. And something else of note in this EKG, the algorithm is saying that it is meeting minimal voltage criteria for LVH. Okay, so if it's meeting minimum voltage, it's talking about LVH. Why aren't you seeing left axis deviation? So would it make sense that if we're looking at an EKG that has left ventricular hypertrophy, that we would have a left axis deviation? And what I'm trying to get you to do here is kind of put the pieces, together on this 12 lead and figure out why this interpretation is the way it is. And anyone? Why don't we have left axis deviation? It tells us, that second line tells us why we don't have left axis deviation. Okay, well, the algorithm is saying, this may be a normal variant, second to early repolarization, but it makes probably just as much sense to say, okay, we're not seeing the left axis shift quite yet in this particular 12 lead, but we, as the disease process continues, we, left ventricular hypertrophy and left axis deviation is a distinct possibility. And we can confirm that because the machine is saying, at this moment, this 12 lead meets minimum voltage criteria for left ventricular hypertrophy. So, we're moving towards that family, but we haven't married into that family quite yet. Okay, does that make sense to everyone? All right. Chris, anything you want to add here?
Not so much, maybe just a little bit.
Yeah.
If you notice on this ECG, there is also some benign early repolarization. So if you look at it, it looks like there's some elevation in V2, V3, maybe a little bit in V4. Oops, V4, V5 and V6. But remember, we have that little notching here. I'll circle it there. You've got a concave elevation pattern, right? All that suggests that we're dealing with benign early repolarization. So that could be part of it too. So this is just like many things in medicine, it's not super exact, even 12-lead ECG monitoring. So there's going to be a little bit of variation. So this is kind of a normal, more or less a normal variant of what we see. And then you got to take into consideration who this is, and what comorbidities they may have, how old they are, and so on. But that's all I'd say there.
Okay, Chris, don't be shy. If I'm butchering some of your thoughts here on your notes, you jump right in there, okay? All right. So let's move on. I'm actually going to really quickly, I'm going to skip over this and we're going to come back to it when we start talking about bundle branch blocks. Okay, because I think there's a lot there. I really want you to focus on right now, for the moment, looking at lead 1 and lead AVF. Okay, those are the two primary leads that I want you to memorize and focus on, and then we can expound on that as we move along. All right, so let's see. What's next? Let's do some more practice. Because you can kind of get without looking at the limb leads, you can kind of get the general gist of what's going on in these 12 leads. You can get a down and dirty estimation of axis. So let's look at this 12 lead. Remember, looking again at lead 1, which way is our QRS going? It's positively deflected. So we have a positively deflected QRS in lead 1. And what about AVF?
Negative.
Yeah, you have a negative deflection in lead AVF. Again, this tells us that the impulse is moving towards the positive pole of lead 1, but away from the positive pole of AVF. So if we get a mental picture of a vector moving, towards the positive pole from the right shoulder to the left shoulder, but away from the feet and towards the head or caudally, what type of axis deviation is that?
Left.
Left axis deviation, absolutely. Everybody got that. Everybody see that.
Yeah. Hey, Ronell, what
Yes.
makes this LAD pathological? How can you tell from this EKG that axis is beyond that 30 degrees? Is there a way, or?
Not from this EKG, because you don't have the QRS, you don't have that header that tells you what your QRS degrees are. So you can't nail down exactly, and that's the drawback of the down and dirty 1 in AVF. um, you can't tell exactly how many degrees off this particular QRS is, as far as I understand. Chris, you want to add anything here?
Yeah, I will. And this is where the limb leads comes into to play. Now, I want to be very clear. I need to be absolutely unambiguously clear about this. Where we definitively determine axis when you're looking at somebody's 12 lead is you go to that printout and you find the QRS axis or the R axis. And whatever that is the QRS axis of that patient, right? So that's kind of the definitive a way of figuring it out. But when it comes to differentiating between physiological and pathological left axis deviation, you can use the limb leads. It requires a little more nuance, but you can use leads 1, 2, and 3. And if you remember from Einthoven's triangle, so if I draw Einthoven's triangle here, right, lead 1 looks, the positive electrode is at 0 degrees there, right? And then you've got lead 2 right here. And then you've got lead 3 right here. So the positive electrode for lead 2 is down here. Positive electrode for lead 3 is down here. So if the electrical activity of the heart is moving in a normal axis, right, the electrical activity is more or less moving toward the positive electrodes of all the limb leads. And so all of your limb leads will be upright, 1, 2, and 3. And remember, we talked about this on the first day, the first lab we did, when you print off a 12 lead, look at the limb leads and make sure they're all upright. Because that's a sure way of knowing that you put all of the electrodes on and you don't have limb lead reversal. But what happens is, as you become more left shifted, all right, so as you become more left axis deviated, so let me draw that. All right, so 0 to 90 is the normal axis here, right? So as I become more left shifted, right, the electrical axis is moving in that direction, right, up above 0. And so what's going to happen is with physiological left axis deviation, right, so lead 3 is looking in this direction, right? The positive electrode for lead 3 is down here. And so you're going to begin shifting away from lead 3. So what you're going to get is you're going to get downward deflection in lead 3, but you're still going to have upward deflection in lead 2. And what's going to happen is the more and more shifted you become, the more and more likely lead 2 is to become negative. And the defining, the delineation between physiological and pathological left axis deviation is when you have deviated into proper left axis deviation territory, you will be moving away from the positive electrode of lead 2 down here, right? And when that happens, you will have a downward deflection of lead 2. So pathological left axis deviation is up, down, down. So 1 is up, 2 and 3 are down. And that's how you can tell that you've transitioned into pathological LAD territory using the limb leads. It looks like iPad logged in. Do you want me to go ahead and let that take over?
Yeah.
All right, so I'm going to stop mine. And let me just make that the co-host. And you have control, sir.
Awesome. Thank you.
But did that answer the question okay? Does that make sense?
Yes, it did. Thank you.
Okay, great, no problem.
So, okay. let's see. All right, are you all actually looking at bundle branch block? Or are you all still looking at a 12 lead?
Bundle
Go
branch
bundle.
block.
Awesome. That's what we, okay, here we go. All right, so I wanted to kind of venture into bundle branch block, and you'll understand once we get into this just a little bit why we chose to put axis first. Because when you talk about bundle branch blocks, you are actually talking about axis, about the mean direction of forces in the heart, and what happens when the normal pathways of those, the normal conduction pathways of the heart become blocked, and those forces have to take another route to get their job done. Okay, so let's remember that, let's say, for an analogy, that we are taking a trip to Albuquerque. Okay, and what would be the fastest way to Albuquerque? Would the fastest way to Albuquerque be I-25? Or do you think, oh, well, the faster way would be the surface streets? We're going to take back roads and surface streets in order to get to Albuquerque. Well, logic tells you that the interstate, barring any type of traffic issue, is going to be the faster way to get to Albuquerque as opposed to the surface streets. Okay, so that's the way I would like you to think about the normal cardiac conduction system of the heart. These, from the SA node, where you move down the interatrial pathways to the AV node, this is an interstate. Oops. I'm having nothing but technical difficulties. Okay, so that is actually, the normal cardiac conduction pathway is considered the interstate because it's the fastest way for an impulse to get from point A to point B. All right. So when we talk about bundle branch blocks, we're talking about when there is construction on the interstate and the interstate is blocked and we have to take another way to get to where we want to go. And this construction is not a positive phenomenon, as if road construction ever is. But it's not. This road construction isn't focused towards improving the pathways that we take. This actual construction is a phenomenon called remodeling. Or part of a phenomenon called remodeling. So when the heart is sick and not functioning appropriately, the heart kind of has to remodel to deal with, as a physiological consequence of some sort of malady, okay, such as an MI, or such as calcification, or such as one of our pacemakers infarcting or being ischemic. So this remodeling is a reaction to a medical condition, physiological consequence of illness of the heart. Okay, so when we talk about left bundle branch block, again, it's going to be very important for you to remember which leads lie where, because that's going to tell you, what leads you can use to look at what, and it also tells you, how to exclude certain things that show up in one lead, that you would normally see in one lead, or for want of a better word, it will help you to figure out pathologically what is going on. Okay, so the leads that we are going to use in determining bundle branch block are going to be leads V1 and V6. So why do you think we're going to use these leads? Why are these our preference? V1 and V6. Well, because V1 and V6, most accurately gives us the picture of what's going on between the ventricles, the interplay between the left and right ventricle. Now, some folks will use, in lieu of V1 and V6, some folks will use lead 1 and V1. I, by convention, am going to use, V1 and V6 because I do think that it shows a fairly accurate picture of what's going on and the interplay between the left and right ventricle. Okay, so in the normal cardiac conduction, remember we said that we have an impulse. We're taking one single pacemaker impulse, comes from the SA node, goes to the AV node, gets held up in the AV node, goes down this interstate pathway to the bundle of His, and from the bundle of His, we have it breaking off into the left and right bundle branches. Okay, so this impulse, as it breaks, it actually initiates depolarization of the interventricular septum. So this area here is called the interventricular septum. Okay, so as that impulse travels down, it initiates the depolarization of the interventricular septum, and then the impulse breaks out to the right and to the left. And remember, we said that the right bundle branch has one single fascicle, and as it goes through the right fascicle, it breaks down into the Purkinje fibers, and that electrical impulse propagates, and you have depolarization and thus cardiac contraction. On the left side, same thing, but remember we said we have two fascicles. We have both the anterior and posterior fascicle. Okay, and as the impulse travels through the left, anterior and posterior fascicle, that leads to depolarization of the left ventricle. Now, in the normal heart, this is what this is going to look like. So I labeled here V1 and V6. So when we have that impulse that initiates and travels down the ventricles and causes depolarization of the ventricles in the normal heart, those ventricles depolarize and contract at the very same time or close to the same time. Okay, and that is what is known as ventricular synchrony. Okay, and that is very important. Having those ventricles synced up where they beat at the same time, where they contract at the same time, has a profound effect on cardiac output. All right, and just remembering that little fact will assist you as we start talking more about some cardiac pathologies and cardiac disease processes as we move forward in your training. Okay, so let's look at what this is going to look like on a 12 lead. So before we can, look at what a right bundle branch block is going to look like and what a left bundle branch block is going to look like, we need to understand what normal is going to look like. So I'm going to draw this out for you, hopefully, and I hope you get a better understanding, of what is actually happening in the heart. It's critical for you to understand, why am I seeing the type of deflections that I'm seeing, what's actually going on in the cardiac conduction system. Okay. We don't expect you to, have this all memorized by today or remember it all by tomorrow. This is going to be a process. Again, this is going to have to be something that you revisit time and time and time again. I admittedly am a little slow, and it took me a few years to actually understand bundle branch blocks beyond, hey, look, part of the cardiac system, conduction system is blocked and not working appropriately. Okay, so just keep that in mind. So in the normal heart, if we look at V1, we have our impulse that comes down from the bundle of His and depolarizes the interventricular septum. And then roughly this depolarization propagates down the interventricular septum, and then it moves out into the ventricles simultaneously. Okay. However, so let's do this to kind of declutter this picture a little bit. We'll go here and we'll make V1 out here to get it out of our field, and V6 here. These are our leads. Okay. So in normal cardiac conduction, again, interventricular septum depolarizes first, then the force propagates down through the right fascicle, and then through the left anterior and posterior fascicle, and then out through the Purkinje fibers. Okay. However, remember we said that, we know that the left ventricle is thicker, so therefore you're going to see more energy propagation, and that's going to cause you to see this. So in V1, if we think about normal cardiac contraction, we said that the average or the general gist of the direction of energy in the heart is moving downward and to the left. So this axis is moving downward and to the left. That's what the 12 lead sees. And so that shows us, remember that these unipolar leads, these precordial leads are unipolar. They're one pole, and they are they're identified as positive unipolar precordial leads, right? So using what we know about axis, if we have a vector moving away from V1 towards V6, what type of deflection do we expect to see in V1 in the normal cardiac cycle?
Upward.
Yeah, so initially we will see when we have initial depolarization, we actually will have the impulse moving toward V1 just briefly, but then that is kind of masked by the depolarization of the left ventricle. So initially, we might see a little bit of an upward positive deflection in V1 for our QRS. Okay, so we have a positive deflection in V1 initially because the impulse is traveling towards the positive pole of V1, again, initially. But in V6, initially, the impulse is traveling away from the positive pole of V6. So we would expect to see a negative deflection in V6 initially. Okay, everyone with me? All right. Then, like we said, the electrical impulses propagate roughly equally through the ventricles. However, remember we said the mean axis is moving downward to the left. The 12 lead actually sees more of the left side than the right side. And if it sees more of the left side than the right side, we are going to have a positive deflection in V6. initially, okay? And a negative deflection in V1, because again, the impulse is traveling downward and to the left, all right? And again, since the left side is more muscular, we're going to see that as more prevalent. And then finally, we have our ending of a negative deflection as the impulse travels from the right to the left and wraps around the backside of the heart. Moving away from V6, we'll see a negative deflection in V6 and a positive deflection in V1. So I'm going to clean this up a bit. Again, excuse my artwork. So what this will look like is something like this. And this will look like this. Okay. Okay. Everyone with me there. Chris, anything you want to add for normal? Chris?
Yeah, I'm sorry. I'm just trying to pull up a let's see here. Just gonna pull up an ECG, or do you have an ECG?
I do.
Okay, never mind. No, I'm good then. Keep going.
Okay. Are you good or no?
Yep, I'm good.
Okay. All right. Okay. So that's what we're looking at in a normal cardiac conduction system. Okay. Everything propagates, down the interstate through the normal conduction pathways. It travels fast. And I'm not being very clear as far as my drawing about what's going on in that. I keep making these wide QRSs, but you have to remember the QRS is not going to be wide because we're talking about normal conduction through normal pathways. And we're talking about normal conduction through normal pathways. We're using the interstate. So the end impulses are traveling faster and they're getting where they need to go quickly. Okay. So that is normal cardiac conduction. Now let's go a little further. And talk about bundle branch blocks. And we're going to start off with a right bundle branch block. Now, there are a lot of criteria, guys, on what leads to look at. And this has to be present in this lead, and this has to be present in that lead for you to call it a right bundle branch block or a left bundle branch block. I'm just going to give you sort of a prima facie presentation of this information because I don't want to bombard you and overwhelm you. I think as long as you get the fundamentals of it and just look at it from the very beginning, it will stick with you longer and it'll be easier for you to digest and consume. So we're just going to do just a very quick prima facie introduction. And we're not going to dwell down into any rabbit holes. And hopefully, you'll catch on, and then we'll build on that as we move along. All right. So let's see. Let's talk about a right bundle branch block in general. All right. Now, one criteria that absolutely must be met before you determine that something is a bundle branch block is an absolute, is your QRS duration has to be greater than 120 milliseconds, or 3 small boxes. Okay, so your QRS duration has to exceed 3 small boxes, or 120 milliseconds, or 0.12 seconds, however you want to say it, it's the same. But this criteria must be met. If your criteria is, or if your QRS is less than 120 milliseconds, we're not going to consider that a bundle branch block. That's more than likely non-specific endoventricular conduction delay, which we'll get into in a little bit. Okay, so that's the first criteria that needs to be met. All right, is your QRS is greater than 120 milliseconds. And we have to remember that in order for it to be a bundle branch block, this rhythm must be supraventricular. Supraventricular, okay? And that means that we are not dealing with ventricular rhythms, okay? If the impulse is initiated in the ventricles, that's going to be a ventricular rhythm. And of course, your QRS is going to be wide, okay? So it's important to remember that your QRS has to be greater than 120 milliseconds, and the rhythm, the initiation impulse must come from above the ventricles. Okay. So let's look at a right bundle branch block. In a right bundle branch block, so we have our impulse again that comes down from the SA node, stops at the AV node for a predetermined period of time, get our PR interval, and we have that AV node stop us, and then we go down to the bundle of His. And propagate likewise, okay? In a right bundle branch block, our right bundle branch is blocked, okay? We have a block there. Remodeling is going on, construction is going on. So what ends up happening is this impulse is stopped, and this impulse on the left side continues normally. Okay, it continues normally. So what does that look like on our EKG? So we said in a right bundle branch block, initially, everything looks fine because we have the impulse come down to the endoventricular septum, to the bundle of His, and initially, everything looks great, and we have this upswing because initially, we do have in V1 this cardiac vector that's moving toward V1. Okay. And then what ends up happening is we meet this roadblock in the right bundle branch, and we come to a stop. Okay. And then all of a sudden, the impulse has to move away from V1 because it's been blocked. And instead of taking the interstate, this impulse now has to take the surface streets or cell-to-cell propagation to depolarize. So you get this quick movement away from V1 toward V6. And then as we have the cell-to-cell propagation, you'll start to see the right side depolarize, and you'll have a positive vector again. And then finally, as that cell-to-cell impulse propagates back over to the left side, away from V1, you'll see a downward deflection. So let me clean this up. And hopefully we can make this make a little more sense. If we were to clean this up, we would get something that looks like this. Okay. And this is a very typical, for one, my artwork notwithstanding. This is a very typical presentation of a right bundle branch block, because what you have here is you have this R wave, and then you have this negative deflection, which goes down into an S wave, and then you have this other R wave. This morphology is known as a classic RSR prime wave. Okay, because you have your R wave, your S, and your R, known as RSR prime. And you may also hear folks refer to it as rabbit ears or bunny ears. Okay, I don't want you to get into the habit of looking at this type of morphology and going, oh, that's a bundle branch block. I see bunny ears, and bunny ears is indicative of a bundle branch block. That is not true. You can have sort of a bunny ears morphology and it be indicative of something else. Okay, so one of my friends, I love in his presentation, he says, you know, bunny ears are for suckers. Bunny ears do not always indicate a right bundle branch block. What actually indicates a bundle branch block, a right bundle, is actually that QRS duration being widened. Okay, so what constitutes a bundle branch block is a widened QRS and not this morphology of rabbit ears. Okay, Chris, anything you'd like to add with right bundle branch block?
No, I'm good.
Okay. All right. So that's right bundle branch block. Now, if we were to look at this from B6, instead of having sort of this, you know, upward RSR, that looks sort of like an M, typically in B6, we still get this sort of bunny ear. I just told you not to use that, and I'm using it. You still get this double waved morphology that kind of ends up looking like a W. I keep pressing down. Let's do this. It doesn't like when I continue to have contact with the, so let's make this quick. Okay, you kind of get this W looking in V6. Okay, that is just that wave in V1 kind of flipped. All right, so that is your classic right bundle branch block morphology. That's how right bundle branch block presents itself in terms of shape. All right, so now let's talk about left bundle branch block. So in left bundle branch block, the exact opposite is occurring. So again, we're going to start SA node, AV node, like we know, down our internodal pathways, onto the interstate, down the bundle His, and then you have depolarization again of the endoventricular septum. Okay, but in this case, you have a left roadblock. So a roadblock on the left bundle. But on the right side, the impulse propagates as normal. Okay, so what does that look like on an EKG? So in V1, again, initially in a left bundle branch block, initially you'll have just a little bit of an upwave, but then all of a sudden, because your left bundle is blocked, here again, you'll have the impulse moving away, and you get this negative deflection in V1. And as it moves towards the right side of the heart, it'll wrap around the right side again because the conduction system to the right is fine. And instead of, again, going down the left bundle branch, the left interstate, it has to go cell to cell on the surface street. So it'll wrap around the right side of the heart and propagate cell to cell and then depolarize the left side of the heart. So as it moves away, you get this negative deflection. And then as it does the cell to cell propagation and starts moving toward, you get positive deflection and then a return to baseline. Okay. And that is your left bundle branch block in V1. In V6, you sort of get the same looking wave.
Hey, Ronell, real quick.
Yes.
So you don't get the R to SR prime wave in the left then? Or you do?
It's usually indicative of a right bundle branch block. You get something, you can get something that looks sort of like this, but typically your RSR prime, the kind of bunny ears, upward facing bunny ears, is indicative of a right bundle branch block. Chris, anything you want to add there or clarify?
No.
Okay.
Gotcha.
All right. So that is bundle branch block. Now, what is the physiological consequence of this? Or I should say the pathological consequence of this. What is so dangerous about this bundle branch block besides, ending up having this progress towards a high degree of block and perhaps total AV dissociation is you lose your ventricular synchrony. You lose both of your ventricles contracting at the same time, and therefore that is going to affect your cardiac output. In fact, your left and right ventricles can become so dysynchronized that you actually have to get a cardiac pacemaker implanted to kind of restore ventricular synchrony. Okay, so that's left and right bundle branch block. Very, very surface sort of presentation of it. We're going to take a quick break and we're going to move into Scarbosa criteria, and we'll talk a little bit more about bundle branch block, but specifically we're going to talk about how to determine STEMI in the presence of a left bundle branch block. For many years, it was said that, oh, you can't do it. You can't do it. Somebody, if they're actually if they have a left bundle branch block, you're just better off if they're having symptomology, go ahead and treating them for an MI because there's no way you can determine that a STEMI exists. And it turns out that that's not true. So this time we're going to take about another, let's take 15 minutes. And I'm going to go stick my iPad back in the refrigerator and we're all right. So we're going to give you just really quick way to differentiate, you know, left from right bundle branch block. Really quickly, can you hear me? Am I unmuted, Chris?
Yep, I can hear you just fine.
Okay, awesome. All right. And I want you to keep in mind, again, I'm really doing a surface, like a 10,000-foot view of bundle branch blocks, because there are more criteria. So, I gave you just the prima facie example of right bundle branch block, along with our criteria of a QRS duration greater than 120 milliseconds. More criteria is, if you look at V1 and V2, you need to have a very prominent R wave, a distinct R wave, and then you'll look in V5 and V6 and AVL, and should have a broad S wave. There are a lot of criteria, okay? So just keep in mind that I'm just giving you the beginnings of determining what bundle branches are, how to determine them. But there are a lot of other leads you can look at, and a lot of other criteria in those leads that you look for. All right. Okay. So keeping, that mantra of simplicity in mind, determining bundle branch blocks. One of the best known ways, and I think one of the simplest ways of determining bundle branch block, is something called the turn signal method. Okay. And to utilize the turn signal method, you are going to go to V1. And in V1, you're going to find the J point. And once you find the J point in V1, so you're going to find the J point, then you are going to go to the terminal wave. And when I say terminal, you'll hear that a lot. The terminal wave, a terminal S wave, terminal R wave. Terminal just means end. Okay, the last. So you're going to go to the last wave, terminal wave, and you're going to look at what deflection it's pointing in. So in V1, find the J point, and then look at the last wave, and it is a positive deflection. Okay. And if you have that positive deflection, that QRS pointing upward, and you notice this area here is shaded in, that is a right bundle branch block. Likewise, if you go to V1, find your J point, go to your terminal, look at your terminal wave, and if that deflection is downward, that is going to be indicative of a left bundle branch block. And this makes sense in reference to the turn signals, because we know that, when we're driving a car, if we want to make a right turn, we push the turn signal lever up to turn right, and we push the turn signal lever down to turn left. Okay, so that's an easy way to remember the difference between a right and left bundle branch block. Again, looking at V1. All right, we'll use that turn signal method utilizing V1. Chris, anything I missed there?
No, sir.
Okay, so let's practice. All right, let's look at some practice strips. So let's look at our first practice strip. All right, in our first practice strip, utilizing our turn signal method. Remember, we said we're going to go to V1, our J point, and find our first terminal wave. And what direction is that first terminal wave pointing in?
Up.
Is it pointing up? This wave right here. Which way is that wave pointing?
Push it
Down.
It's pointing down, correct? All right, and we said we pulled the turn signal down to turn which way?
Left.
Absolutely. So this is a what? What type of bundle branch block is this?
Left.
Absolutely. It's a left bundle branch block. And we can confirm this by looking at criteria in other leads. I don't want to go into that quite yet, but we can confirm this by looking at some criteria in some other leads. There is something significant. There's a lot significant about this particular EKG. One of the most, one of the things that really stands out, one of the pathologies that stands out is what? So think about this. You have a left bundle branch block. And that makes sense because what else is going on in this EKG? What else is going on in this EKG? Okay, so let's look at our V leads here. And let's see if we can't paint the pathological picture of what's going on with this heart. What our V leads here, do we see something strange in the V leads? Speaking.
That's the elevations.
Is that left ventricular
Well,
hypertrophy?
yeah, absolutely. You would expect to see ST segment elevation in this EKG because there is a left bundle branch block. Okay, and in order to differentiate, do we actually have a STEMI going on? We're going to use Scarbosa criteria, which we're going to discuss after lunch. Okay, but more specifically, what we see going on in this EKG is left ventricular hypertrophy. And we see, you look in V1, you look in V2, very much so in V2 and V3, you have these long slurring QRS complexes. And again, this is voltage criteria for sure for left ventricular hypertrophy, okay? And this, painting the entire picture here, so this guy or gal has, a defect in their left conduction system, their left bundle branch is blocked, probably diseased, and they're probably suffering from left ventricular failure. They've got some left ventricular wall thickening, left ventricular hypertrophy. So that kind of paints, sort of the total picture, and it makes sense that, hey, this person has a left bundle branch block. The left part of their heart is really struggling. Okay, this is a sick heart. So that kind of paints, a pathological picture for us there. All right. So let's go to our next example, our next practice. What about here? What does this 12 lead show?
Same.
Yeah, absolutely. Going to V1. And we look at our terminal wave, our terminal R. And we look and it's actually negatively deflected. Okay, it's actually negatively deflected, which is indicative of a left bundle branch block. Okay, and we can confirm that looking at other leads. All right.
Hey, Ronald,
Yes.
is the left ventricular hypertrophy going to be something that presents itself in a lot of the cases or more, all cases?
To be honest, it's going to depend on how far along the disease process is. We have early parts of the disease process. So let's say, the patient has chronic hypertension and the heart is actually, pushing against more force, more afterload to push blood out to the body. Okay, is it early in that process where you haven't had a chance to have significant left wall hypertrophy, left wall thickening? So it all depends. You can actually, we do have left ventricular hypertrophy here and it's fairly advanced, but you have cases, of course, all disease process has to start somewhere. So it just depends on how soon or how late you catch it in the continuum to, on what components you'll have on your EKG. Does that make sense? Did I answer your
Sure, got it. Yeah, thank you.
Okay. So let's go to our next practice 12.
So Ronel, quick
Yes.
thing. This might be a little redundant, but So to rule out a STEMI, even with a left bundle branch, we're gonna treat a bundle branch like a STEMI.
Okay. I'm going to address that after lunch, but yes, I would say you need to err on the side of caution. Scarbosa criteria is a lot to remember. Two of the criteria are fairly well proven. And then there's a third criteria, two of the criteria can identify STEMI in 90%, over 90% of cases where left bundle branch block is present. But the third criteria, its actual accuracy is right around 50%. Now, I don't want to talk too much outside of what we're doing, but there's also a Smith's adjustment. Dr. Smith came in behind Dr. Scarbosa and said, okay, this third criteria is a little flimsy. Let's see if we can't shore it up a little bit, but I don't want to go too far into that. So to answer your question, if you have any doubt at all, treat it like a STEMI. Again, it's much better to treat something like a STEMI and it not be a STEMI than you not treat something like a STEMI and it's an actual STEMI. Okay.
Okay, gotcha. Thank you.
Absolutely. All right. So this next practice 12 lead, what are we looking at here? Just in terms of bundle branch block.
Another
Left bundle branch block.
Yeah, again, you're having that left bundle branch block. Like we said, find your J point, terminal R, figure out which way the wave is headed. It's headed downward, left bundle branch block. Okay. Everybody got that? Everybody with me so far? Okay. So what about here? Looking at
Right.
B1. It's what?
Positive, so right.
Yeah, absolutely. You have this right bundle branch. You find your J point, you move backwards, find your terminal wave. The deflection is actually pointing upward. We said, using the turn signal method, you pull the lever upward to turn right. So this is a right bundle branch block. And you start to see this classic morphology of this RSR prime. Okay. Classic for a right bundle branch block. Okay. And you can really see it in V4. Of course, again, dare I say, the bunny ears, but you can see it in V4. If there's any doubt, right bundle branch block. Okay. And another practice.
Left.
Absolutely. Everyone see that? I'm gonna go through. Everyone see left, that's a left bundle. Again, your terminal wave negatively deflected. Okay. All right. All right. So that is bundle branch block. How is everyone feeling about that? Are there any questions?
All good here.
Okay. Anybody unclear on what we covered so far? Again, the way you're going to get this is you're going to have to go over it time and time and time and time again. You're going to have to see it anytime you're in your rotations, anytime you get out on an ambulance at your job or what have you, and you have an opportunity and run a 12 lead on your patient. Run a 12 lead and interpret that 12 lead. If you're in the hospital, you got some extra time, look at the patient's chart, look for their 12 lead. And I will tell you, the hospital is a great place to do it because you can actually get serial 12 leads. If you have a patient that's a STEMI or something that they're concerned with cardiac wise, you can actually go into their chart by date and take a look at actual serial 12 leads. And perhaps you can pick up the progression of a disease process. So, all right, if there are no further questions, we are going to break for lunch now. It's 11 o'clock.
Actually,
Chris?
yeah,
Oh, yeah, go ahead, Chris.
I just wanted to review something real quick because it shouldn't take a whole lot of time. And then that'll leave us more time to focus on Scarbosa and modifications thereof after lunch.
Okay.
Oh, okay. Yeah, I just I didn't want to step on you though. I want to make sure.
No, we're good. Go ahead.
Cool, cool. All right. So so I also just want to reiterate a couple of things. When it comes to bundle branch blocks, okay, if somebody is, say, they have ventricular tachycardia, or they are in a ventricular escape rhythm, or they are having things, ectopic complexes like PVCs, where stuff is coming from the ventricles, you can't say that somebody has a bundle branch block based on that. Okay. Is everybody okay with that?
Yes, sir.
Okay. Because I think it's very tempting to now that you have this knowledge to begin to apply it to where it doesn't or shouldn't be applied. So when it comes to like PVCs and ventricular tachycardia, you got to remember that that is a focus or foci that is in the ventricles. And the reason that the QRS is so wide is not necessarily the bundle branches being blocked, but that is that impulse is starting in the ventricle and it is moving up in a retrograde manner, right? And the way that it's supposed to move through is from the top down. And so what happens is that conduction becomes delayed as it is moving in that retrograde manner, and it's slowed. And that's what causes the QRS to widen out. So not all wide QRS complexes are bundle branch blocks, right? So
Chris,
yes, sir.
sorry to interrupt. So it'd be safe to say that a bundle branch block still has an underlying sinus rhythm to it?
Absolutely, yes. So when you talk about a bundle branch block, you're typically going to have a sinus rhythm, or you're going to have a supraventricular pacemaker. So you can have a sinus rhythm with bundle branch block, a sinus bradycardia with bundle branch block, sinus tachycardia, sinus arrhythmia with bundle branch block, or you could have atrial fibrillation or atrial flutter with the bundle branch block. And it is conceivable that you could have a junctional escape rhythm with a bundle branch block, but in that instance, that's going to look just like an idioventricular rhythm. So that's going to be really hard to tease apart. So in that case, you would just default on, you would error on it being an idioventricular rhythm, because that tends to be worse than a junctional rhythm. But does that make sense?
Yes.
Cool. And then there are also some other things that aren't technically bundle branch blocks, but may look like bundle branch blocks, like Wolff-Parkinson's White we talked about earlier, where you get those delta waves, that's the initial slurring of the QRS, and the QRS widens out. Again, that's not due to the bundle branches being blocked. That's due to that accessory pathway that's depolarizing. And so it can kind of look like a bundle branch block. So you can see that we're being fairly topical here, but I just want to make sure that, right, I don't want anyone to look at VTAC and go, oh, that's a bundle branch block. Well, wait a minute, that's not exactly the case. Excellent. Okay, good. So I just want to make sure everybody's okay there. So before we break for lunch, there is something that I do want to discuss briefly, and this, I suppose, is as good a time as any to talk about that. And let me just go ahead and bring my notes up, and I'll share this with you all very quickly. All right. And that is a question I believe was asked the end of last week, or it may have even been yesterday, and that is in reference to AVR. Somebody asked about AVR. So what I'm going to do is I'm going to go ahead and share with you all. All right, that looks good. Go to my notes here, get rid of that. All right, so let's talk about AVR. So we've pretty much neglected AVR when it comes to ECG interpretation, and that is for some reason. So let's just give AVR a little bit of love, if we will. All right, so augmented vector right. So AVR, in terms of what it looks at, so the AVR, unlike the other leads, is not really in touch. It's not really in touch with any specific area of the heart. All right. So AVR is not in touch with any specific area of the heart. So what I'm going to do is I want to give you all an example of a 12 lead here. So let me go ahead and do that real quick. And I'm going to show this 12 lead to you all. And I want to ask you a question. Does this 12 lead meet criteria for STEMI? All right. So here it is. Let me get that out of the way. Let me zoom in a little bit. All right. So here's a 12 lead ECG. All right. Does this 12 lead meet one of the two major criteria we use to determine STEMI in a pre-hospital context? And if you answer yes or you answer no, remember, I am the physician, ER physician at the hospital. I'm going to call you out. So I'm going to say, okay, if you say this is, you damn well better explain to me why you think this is a STEMI, how this meets criteria that you've been taught.
I can't read
So
the
what are
box
the
if
two
you
major,
are
you can't what?
the boxes on it. To meet the criteria, if it's in one greater than two, or if it's in two or more leads greater than one in each. I can't
Okay,
really
so
read the boxes.
so good, so excellent. So at least you know the criteria there. So just kind of looking over, gestalting it, does anything like jump out at you?
It's just the elevation and AVR and then the depression in one.
Yeah, so really the only thing that's jumping out is AVR. See if it'll let me draw on it. Is this elevation here? And I know it's kind of hard to see the boxes, but clearly, there we go. I'm getting a lot of lag. Let me stop my video. There we go. So clearly, that's substantial. And then if you look over in your V leads, you have some, just some super subtle changes. So just really subtle stuff going on in V1 there. But asking you the question, and you do have a little bit of depression maybe here in 1 and 2. So based on criteria that we've taught you, Suar, would you feel confident calling this a STEMI?
No.
No. And you're right. This doesn't really meet the major criteria that we've talked about. So this is where AVR can actually play a very important role. All right. So going back to AVR, not in touch with any specific area of the heart, but what I want you to think about AVR is I want you to look at AVR as kind of looking at the heart from a 30,000 foot view. So AVR is kind of like looking at the heart from on top of a mountain, right? It can't localize, right? Looking at something in the mountain, it's not like you can really localize if you're looking down at a town, for example. You can't really localize things because you're so high up, you're so far away. But you know, if there's a big fire going on, you can see all that smoke rising up from the town, and you can point and go, holy cow, there's a big old fire going on, right? And that's kind of what AVR is like. AVR is kind of like a 30,000 foot view of the heart, if you will. All right. And so the major take home point, there's a lot we can say about AVR, but the major take home point I want you all to know at this point is when you have elevation in AVR, all right, this tends to be the result of global ischemia. That is to say that you know, to see that fire from the top of the mountain, there has to be a lot of smoke coming up for you to see it, right? So to see ST elevation AVR suggests that there is something going on that is impacting a significant portion of the heart, even if you can't localize changes that meet STEMI criteria, right? That ST elevation is like, hey, there's something going on globally. And the major thing that we see, one of the major things that we see is disease of the left main coronary artery. So left main coronary artery disease may present with ST elevation in AVR. And that is to say that there are large areas of ischemia going on. All right. And that's what I want you to think about there. And what can happen is, depending on the dominance of circulation, if someone is highly right dominant, we talked about left versus right and co-dominant. Sometimes if they're highly right dominant, they can get a little bit of perfusion of the left side of the heart coming off the right coronary artery, and it can kind of prevent these substantial in-your-face changes from occurring on the 12-lead ECG. So highly right dominant circulation can change the typical pattern of injury that we see. In addition to that, you can have a substantial problem due to the circumflex artery. And again, if you have someone who's right dominant, right, the circumflex artery and the right coronary artery often will perfuse some of the same areas. So you can kind of, the right coronary artery can kind of pick up slack a little bit, and you can have severe circumflex disease. And you can even have an MI related to the circumflex taking a big hit. And you can have what's known as a silent myocardial infarction when looking at the EKG. That is to say that you do not see the classic patterns of injury, okay? But you may see ST elevation in AVR. And so that's really the big point I want to make is ST elevation in AVR suggests that there's something big and nasty brewing, and you can use that finding and you can call medical control and say, hey, I have kind of these non-specific changes, but I've got ST elevation in AVR, and I am concerned about global ischemia. I am concerned about left main coronary artery disease. I think this is a patient that would benefit from going to a cath lab under STEMI activation. And this 12 lead that you're looking at here, is actually a pre-hospital 12 lead on a 79-year-old male patient that had pretty substantial history. And the paramedic that took this 12 lead ECG decided to do a STEMI activation. They took the patient to the cath lab, and the patient ended up having substantial left main coronary artery disease, and actually ended up making a save. And it was such a good scenario that this ECG in this scenario was presented by the medical director and the cardiologist involved, the interventional cardiologist involved in the case. This is actually happened in Texas, in the Dallas-Fort Worth area. And so you can see that AVR can provide some powerful information in some of these situations. There are other reasons, there are other things that AVR can do, but this is the main one. So I just wanted to talk about AVR real quick, give it a little bit of love. And with that, I think we've gone over quite a bit this morning. So let's see, are there any questions before we adjourn for lunch? Anybody have any questions?
Yeah, would it be at all safe to assume that you could have like reciprocal changes in AVR and lead one because they kind of look like opposite each other?
Not so much. AVR doesn't look entirely opposite of
Right.
of one, because remember the augmented leads are using combinations of the limb leads to create the negative electrode, and then one of the limb electrodes as the positive. But with that in mind, yes, in a sense, because think of AVR as kind of like, here's the heart, and AVR is kind of way here above the heart, kind of looking like on top, way on top, kind of the top right side of the heart, looking down upon it. And so you're right in the sense that when there's large amounts of ischemia, particularly on the left side of the heart, then yeah, in a sense, it kind of is reciprocal. Or it is reciprocal in that you can have all this ischemia, which generally is going to cause ST depression, but you're absolutely right. That's going to present as ST elevation in AVR. So yes, in a sense, that's kind of what's going on. But it's more than just the lateral. It tends to be the left, the entire left, like, an extensive anterior septal and lateral wall involvement. Excellent. Any other questions? All right. Excellent. Thanks for hanging in there, everybody. So let's see here. It's 11:15. How about we meet back up at 1300? Would that work for you, Renell?
Yes, it would.
All right. We'll meet back up at 1300 to go over Scarbosa and associated paradigms. And then I will talk a little bit about the QT interval and some other odds and ends. I might mention fascicular blocks, although for your purposes, fascicular blocks are really not as important. And then I will just briefly mention a phenomenon known as R-wave progression, which is actually something we want to see, but we will get to that later on. All right, everyone, have a great lunch, and I'll see you all at 1300.
Yes, sir.
Yes, is someone trying to get a hold of me? I'm sorry. No? Okay. All right. Well, I'm going to go ahead and stop recording and get this uploaded, and I'll end if everybody's okay.